So first of all, I'd like to thank the Donovan-Gruppe, SOFWERX, SOCOM, and the group for inviting us to speak. This is a very important topic, and we're honored to be here and present today, so thank you very much. So these are the author affiliations for the group. This is the views of the authors, not the views of the government, not the views of the Navy, not the views of my university. So in February of 2017, I literally got this call. This is the State Department. We have a problem. So what happened was individuals began experiencing symptoms late in 2016 of ear pain, tinnitus, dizziness, and cognitive issues. The profiles were all experienced a loud noise or pressure phenomenon before and during the symptoms. All were members or family members of individuals stationed with the U.S. diplomatic mission in Havana, Cuba, and the sound was localized and followed the individuals. In fact, if they opened the door to the outside, the sound immediately went off. So 35 individuals who were symptomatic or at risk were evaluated at our facility at the University of Miami, 25 who were exposed and had symptoms, and 10 who were not exposed but lived with the individuals who were exposed and were in the houses when the individuals were exposed. We also saw 105 unaffected embassy members who we evaluated those people in Havana. They were largely selected by the embassy to see us. However, we did ask to see all the Marines who were assigned to the embassy detail ourselves. So all the individuals at University of Miami underwent a standard history and physical with an additional targeted neurologic history and physical. They all had eye movement tests that included tests for nystagmus, smooth pursuit, saccades and anti-saccades, optokinetic response and vergence responses. They all had standard audiometry, and then a subset of individuals had additional vestibular testing and additional neuropsychological testing. We were seeing these individuals as patients. Only clinically relevant data were collected, and all testing that we did had to be justified and approved by insurance. The individuals we saw were acute and unaffected by the influences of time, variable pretreatment modalities, compensation. They weren't seeing us for workers' comp, and media attention. So when we saw the individuals, they did not know what they were supposed to be presenting with, because at that time, the media had not publicized what the effects were. So they came to us without the ability to kind of know what they should say. The prevalence of the symptoms in the unaffected groups and the affected groups were analyzed with a two-tailed Fisher exact test. This is going to explain the statistics we used in the following slides. And due to the non-Gaussian distribution, we used the lower 5th percentile and the lower 1 percentile of performance to judge abnormalities. And this is up there because there's been a criticism that some of the tests that we're going to present, people that have anxiety or people that have other disorders have these abnormalities, but not to this degree. So that counters that argument. This is a population study, the 140 total, 105 in Cuba and 35 in Miami, distributed as I reported earlier. So here is the presenting symptoms of the groups. So the affected group, you can see they had a great number of them reported dizziness. This is reporting when they saw us in Miami. Cognitive disorders in about half, hearing loss in 1/3, tinnitus in 1/3, ear pain in 28%. And none of the 10 individuals who were in the houses at the same time but were not affected had any of those symptoms. In fact, except for headache, which is a common symptom in many individuals, the affected group had statistically more symptoms than the unaffected group. Notice that again, 96% of the affected group had at least 2 symptoms, and 64% had at least 3 symptoms. Again, symptoms being dizziness, cognitive disorders, hearing loss, ringing in the ears, pain in the ears, or headache. This is the data by group of the 25 affected individuals. So now we're not talking about the 10 that were unaffected, the 25 that were affected. 88% of them had abnormal subjective visual vertical testing. 52% of them had abnormal anti-saccade testing. 83% had chair impulse testing. You can read the slide yourself. And 92% had at least one VEMP abnormality. And let me explain. Subjective visual vertical is a test where individuals are told to take an object that's off-center and make it point straight up. Vestibular evoked myogenic potentials are tests that explore how the organs of gravityception, both either the utricle or the saccule, how they respond to sound. If you have an abnormal VEMP or an abnormal subjective visual vertical, it's telling us that the organs of gravityception, which are the utricle and the saccule, are affected. So what we're seeing is that if you take the subjective visual vertical data and the VEMP data, every one of the affected individuals, all 25 of them, had at least one test that was abnormal, telling us that their utricle or their saccule in at least 1 year were affected. So the organs that tell you whether you're up and down were affected universally in this population. That set of organs is extremely important because that gives you a perception of where you are in space. Not where your head's turning, but how your body is oriented to gravity. And when these organs are affected, when these organs are abnormal in this population and in other vestibular populations, individuals are severely affected. Because if you don't know which way up and down is, you're not really good for anything else. So these are the definitions. Again, you can read them, but what we want to point out is that we're taking abnormalities that are extreme. So subjective visual vertical abnormalities in the lab are 1.5 to 2.5 degrees. We're only accepting over 3.2 degrees and on down. Cervical VEMP errors, abnormal if amplitude is less than 100 microvolts or greater than 35% amplitude asymmetry between the sides. Again, those are much stricter criteria than the standard vestibular lab uses. So if you see arguments that, well, people have these abnormalities with other disorders, not to this extent. Not to the extent we're reporting. And again, that's important because there was a recent article in JAMA where someone said, well, lots of people have these abnormalities. Well, not to this extent. So there were also some cognitive and neuropsychological symptoms that Bonnie Levine, who's at our institution, did this data, so I'm reporting her data. Cognitive fog, inattention, problems retrieving information, and increased irritability. And when you did the testing, they were below the expected level for verbal fluency, for working memory, and for sustained attention. They had difficulty with auditory processing and difficulty with increased levels of cognitive load. Now, while this pattern of abnormalities can be seen in other populations, at least according to our neuropsychological colleagues, the unique pattern that is seen here is unique to this group. So we have a unique set of vestibular findings, and we have a unique set of neurocognitive or neuropsychological findings that are not, that combination is not seen in any other group of patients. The exposure is unknown to date. We're going to talk about that a lot this morning. It could be ultrasonic energy, it could be microwave energy, it could be one of a variety of things. Dr. Balaban's going to talk a lot about directed energy can be produced by cavitation bubbles. I think Dr. Cantun is, or Dr. Giordano is going to speak about this as well. Bubble formation and bubble bursting can produce damage in any hollow space. And candidate spaces exist right in the area of those vestibular end organs. So I use the term utricle and saccule. I think Dr. Giordano's got a picture of those in his presentation. And those organs sit right next to areas where cavitation can occur. So it makes sense that if I'm getting a sound in and it cavitates in that area, it's going to affect those two gravity organs, the utricle and the saccule. The aura of mild traumatic brain injury. I use this term because if you really break down the term mild traumatic brain injury, it's simply injury to the brain that is mild and that occurred from trauma. And it's synonymous with concussion, nothing more. So if you say you have a sprained ankle, you have a sprained ankle. If you say you have MTBI, all of a sudden you're some mystical creature who crawled out of the lagoon. It doesn't make any sense because, again, medically it's just traumatic damage to the brain that's mild, just like traumatic damage to the ankle that's mild. So one important question we're always asked, we were asked by the State Department, we were asked by DOD, we were asked by CDC, and we were asked by NIH is this, what you're seeing, what you saw in these Cuba patients, is this traumatic brain injury? This is the definition of the traumatic brain injury as determined by the DoD back in 2005, reaffirmed in 2009, and finally reaffirmed most recently in 2017. Individuals suffer a blow to the head. The individual has a period of altered or loss of consciousness of less than 30 minutes. Some groups, not the DoD, but some groups will accept less than 60 minutes. Individual has a sequela. They have a finding after that. And the same individual does not have intracranial bleeding, does not require surgery for the injury, or require an intensive care stay. Essentially synonymous with concussion. Now, I will say that the blow to the head could be either an actual physical contact with the head or could be a pressure sensation in the head. It doesn't have to be physical contact. So that's what the DoD said a year ago and still stands by as their definition for mild traumatic brain injury. Now, it doesn't need to be our definition, but it's their definition. And it's one that we use in a lot of our work because I was in the military for 21 years before this, so I'm a good soldier, or a good sailor. So this is what mild traumatic brain injury looks like if you look at people that were injured in a war. This is data from when I was in San Diego. The acute group was collected acutely when I was deployed in Iraq. These individuals were all within 3 days of having had a injury in theater, usually a blast injury. Subacute group was collected at San Diego when I was there, and the chronic group also at San Diego. To give you some idea about how much mild traumatic brain injury was produced, the number of individuals in the acute group is 88. The number of individuals not shown here in the subacute group, this is all published data already, is 70, and there's about 60 in the chronic group. And that was collected, subacute and chronic, in San Diego over a 2-month period of time at the height of the war in Iraq. A lot of individuals were coming back with brain injury. So notice that dizziness is the most common symptom at all time epochs. Acutely, subacutely, and chronically. They're different groups of people, but again, very similar presentations. So notice that dizziness is there 98% of the time, almost universally in the acute group, and it falls off, but not very much. Headache is the next most common. See it at 72%, 82% at long term. And then you can see vertigo and hearing loss. So for those of you who do vestibular stuff, dizziness in this case was unsteadiness, being off balance. Vertigo is actually a room spinning phenomenon. So there was a lot of off balanceness, not as much room spinning and not as much hearing loss. And notice the high prevalence of headache. This is the ROC curve, again, published data from Kerry Balaban and I in our group, where we take a pair of goggles, the same pair of goggles that we applied to the Cuba individuals. Kerry's going to talk about these a little bit later. And these are the key factors: anti-saccade error rates, predictive saccade error rates, and head impulse testing error rates. Okay, notice subjective visual vertical, VEMP testing are not on there. They're not the key indicators for TBI. They are the key indicators for the group in Cuba. So is this mild traumatic brain injury? The definitions don't match. The findings don't match. Anti and predictive saccades and head threat tests are used for MTBI, whereas otolith findings are seen in those with this syndrome. So different findings. There's a much higher incidence of headache in the mild traumatic brain injury. I showed you anywhere from 76 to 82%, versus the low incidence in this group, 32%. And there's a difference in neuropsychological testing outcome as well that Bonnie Levine showed. So we're not saying this is not MTBI, but this does not fit the military definition of MTBI as described a year ago. So what is it? It's an acquired neurosensory dysfunction with essentially universal otolithic disorders, some additional vestibular findings, and a unique pattern of cognitive findings. Remember, I described for you that otolithic abnormalities at utricle and sacral mean that the individual has an abnormal gravity sense. Now, the site of injury could be limited to the inner ear with secondary cognitive dysfunction, because when you don't know what upright is, essentially, when you're being chased by a tiger in the jungle and you fall down, you're dinner for the tiger. It really doesn't matter if you can balance your checkbook or function cognitively. So it's quite possible, and we have data in our lab with Carrie and Bonnie as well, that show that if you have this dysfunction of what's up and down, you don't have a lot of mental energy left over for cognitive tasks. So the injury could be limited to the inner ear, and the cognitive effects may be secondary to simply the inability to know what up and down is. Or there could be injury in multiple parts of the system. That remains to be determined. But we're working on that now because, again, if you don't know what up and down is, you can't do much cognitively. Most importantly, this is a real physical injury in those truly affected. The 25 individuals we saw had objective findings of a disorder that came acutely from what happened in Cuba. I'm not talking about the word well, I'm not talking about people who presented later somewhere else. I'm talking about people who came to Miami, they didn't know what they should report, and they had objective findings. You can't fake a VEMP test. You can't fake a subjective visual vertical. You can fake it, but it will be apparent to us that you're faking it. So the tests were real and they were objective. And that's important because the 25 most affected individuals, and we're not sure if anyone got affected elsewhere in the world until we do this kind of testing on them. But the 25 affected individuals are often accused of malingering or exaggerating. I can tell you those 25 are not. And that's an important message. Also importantly, these findings suggest the ability to screen potential cases. So otolithic tests, the tests for whether you're up and down, are easy to transport and quick to perform. And a quick cognitive screen could be easily designed. And these screening techniques are critically important for distinguishing the word well, and we already have at least 25 documented cases of word well, from the truly affected. And the fact that these findings are known means, I'm just going to call out groups, they should have been applied to anybody else who complains of this. And we feel that, again, we can design a fairly easy screen, and Kerry's going to show you an additional part of that screen in his talk to really determine who's affected and who's worded well. Because now that it's out there, now that people know what they should complain of, now that they know what the symptoms are, and this is almost all lay media attention, they can fake this stuff pretty easily. And we've had 25 people trying to fake it come to us, and we've been able to rule them out. And any current or future evaluation of cases should include at least this short battery as a screening battery for what's going on. So I'd like to thank a bunch of people because this work doesn't get done in a vacuum. Jan Kaskis, we've been doing work with the Office of Naval Research, funded work with that office for many, many years. They did not fund this work, but they fund similar work. Fred Talishi is my department chair who allows me to do this stuff and see these patients. Tony Etzel is our vice chairman who watches all of our finances at Miami. Even more important for allowing me to do this stuff. Daniela Font is my administrative assistant who scheduled all 35 of these patients from Cuba to Miami. Interestingly enough, almost all the people who saw these individuals were Cubans that work in our clinic. Constanza Pelosi is our research director. Aaron Williams is my research coordinator. The nurses, audiologists, and support staff at the Miami Ear Institute were amazing in helping us with these individuals. And again, we want to thank you for giving us a forum to present this. And we think this is a true story. There are other stories out there. We know this is the real story of at least the acute individuals. Thank you very much.
First and foremost, I want to thank Lieutenant Colonel Snow for inviting us, certainly the rest of my esteemed colleagues, Drs. Hoffer, Balaban, Canton. Thanks very much to SOFWERX for having us down. We'll be back here again in January to spend some time with you. By training, I'm a neuropathologist. I've been doing neuroscience for about 38 years. Very often my colleagues like to call me, and jokingly we addressed this morning, a disruptive neuroscientist because I work in the area primarily of the way neuroscience can be utilized for a variety of different purposes, not all of them medical. And certainly on the medical side, you can do two things. You can help or you can harm. You can withdraw certain types of care and that can be harmful, or the very same things that work on a biological and physiological system through a variety of different anatomical sites can be inductive of things that are at least burdensome, if not threatening and harmful. And that's probably what we've got here. So as you heard from Dr. Hoffer, he got a call early in 2017 that said, this is Department of State, we've got a problem. In the middle of 2017, I got a call from the Department of State that said, Dr. Giordano, we've got a question. And the question is, what do you think we're doing here? What do you think we've got here? We've got this set of findings, and apparently this is going to be some type of problematic issue. My work is fairly well known for the term neuroweaponology. Back in 2006 and 2007, we developed a paradigm by which neuroscience could be weaponized, and we assessed that on the world stage. In 2008, the National Academy's National Research Council came back and said, you know, brain science really is not ready for prime time. That was a misnomer. Our work in 2009-10 and the work of the Nuffield Council in 2013 demonstrated that not only was brain science viable and of value to be weaponized, but in many cases it was already being weaponized based upon older technology that was now taking updates and being put increasingly into a variety of circumstances that would yield individuals to be in harm's way. And we're beginning to see a little bit more of this, and perhaps this is what we're seeing here. I want to start out with that premise because I'm not going to point any fingers, I'm not going to make any accusations. However, what I want you to do is I want you to work with two things: the explicit findings and the implications that those findings give rise to. Particularly in light of the fact that by 2014, the National Academies and National Research Council reconvened and demonstrated that not only were the brain sciences viable, but they were in fact of high value and were in use globally as neuroweapons. Characteristically, when we take a look at neuroweapons, what we think of is drugs, bugs, toxins, and devices. Not all of these things will work directly in the brain. Very often they will work on the peripheral nervous system or on the neurosensory organs to then have a feedback effect that are going to disrupt the process of cognition, emotion, and behavior. What I want you to remember is that these are not weapons of mass destruction. These are weapons of mass disruption, where the disruption can be on the level of the individual and then creating a ripple effect not only on that individual and their cohorts, but on larger scales, socioeconomic scales, geopolitical scales, military scales. Keeping that in mind, it's very, very important to determine a pattern of use, with the implication being that something's going on here. And this was probably, very probably, not an incidental event. Now, could it have been? Yes, absolutely. What is the likelihood of that? Think about it. So if we're talking about things that go bump in your brain, there's a lot of different ways to get into your brain. The primary findings, as you heard from Dr. Hoffer, were primarily otological findings and vestibular findings, things that happen in the ear. And there are two terms I think that become important for you to understand. The first is the idea of otopathology, which is there's something wrong there, and the second is that this may be induced to some toxic event. The initial thought was perhaps these individuals were exposed to some compound, either an environmental compound or an intentional compound, that then caused some type of pharmacological or chemical damage to the organs of the inner ear, whether that organ was the hearing organ, the cochlea, or the organs of balance and orientation, which are the semicircular canals, the saccule and the ampule. There are a number of different drugs that could do this. So we know that there are certain things that we'll call damage to the ear, structural damage to the ear, a blow, a pressure wave. There are certain drugs that can create a toxic effect in the ear, all components of the ear. And what these will then do is they'll affect a variety of the components, inclusive of the nerve that emanates from the ear and goes into the spiral ganglion and then up into the brain. So the idea of an ear-brain connection is not foreign to this type of otopathology and ototoxicity. What are the various signs and symptoms? Hearing loss and tinnitus, vertigo, disequilibrium and nausea, visual features such as nystagmus and oscillopsia, which you heard earlier, and then certainly a whole different types of headache and or disruption of cranial functions. In other words, not only headache, but facial pain, unusual sensations, and then a loss of attentiveness and cognitive functions that can be accompanying this. Next slide, please. What type of things can do this? What type of agents could do this? Well, certainly if we take a look at just defining these into two major categoricals, we have drugs and devices. The drugs that could do this I have listed for you. The likelihood of this being a drug-induced event is very, very low. The reason for that is that the drugs would have to be given repeatedly. Characteristically, it'd have to be given either spike doses that would have another host of effects we call a constellation of effects. This would be notable, and you wouldn't tend to see uniform effects based upon the way the drugs were given. In other words, drugs being given in different doses at different times might manifest distinct effects in different people, and would also not have this particular pattern of presentation. So we can take the drugs and say of those that we would see, would probably most notably those that are anti-tumor drugs like cisplatin and carboplatin, and probably the organic solvents. Once again, these drugs are highly toxic. There'd be no way these individuals would present with this symptom alone and not present with another cascade or constellation of symptoms that would be indicative of exposure to these agents, which then brings us down to the idea of devices. What type of things could it be? Well, it could be subsonic stimulation. It could be ultrasonic or hypersonic stimulation. It could be a combination of both, or it could be some type of microwave or electromagnetic pulse. The idea is that it could be all of these things. These are not mutually exclusive, and very often devices can in fact be manufactured that will combine one or more of these different types of phenomenon to induce a percussive effect. This is not foreign as well. We understand that during the 1970s and 1980s, a number of countries were examining the idea of electromagnetic pulse devices, sonic devices. Some of these have gone into sort of mass market production. Some of these are commercially available. Even today, as Dr. Balaban will illustrate to you, and these are purchasable direct off the shelf. Moreover, we know that there have been a lot of dedicated efforts by nation states, and including from non-state actors, that have tried to work in this area primarily to create weapons of mass disruption. And we see these being used, for example, with varying success on crowds, small aggregates of people, and against individuals. But the problem is that very often, the older technology required fairly large-scale devices to implement this. However, with the sophistication of the tools that we have, we're now able to see this being shrunk down, like so many other things. I'm looking at an audience of a group of people, a variety of ages. Do you remember those first cell phones? They were about the size of a Volkswagen. We felt really good. Yeah, I'm on the cell phone. You had to hold it like this. Now take a look at the size of a cell phone. So what we see is compartmentalization and shrinkage of technology that increases its viability and utility of application. Next slide, please. This is where we're talking about. Ladies and gentlemen, welcome to your inner ear. So if we're looking at the ear, take a look at the slide on the upper left, what we see is that the ear basically has an external meatus, this thing out here, and then there's a canal. There is a membrane, which is the tympanic membrane, the eardrum, to which connected a series of bones, which is called the ossicles. These things will move with a particular stiffness, which will then intrude onto the hearing organ, which is called a cochlea. So there are really two components of what the ear does. First is that the ear hears, naturally. However, we also have to understand that the secondary component of what the ear does is the organs of balance and orientation. These are referred to as the vestibular apparatus, and they include the semicircular canals, or the three looping canals, and the saccule and ampule, as you see here. Now, these are highly vulnerable organs to a number of different things. They're vulnerable to heat, they're vulnerable to pressure, they're vulnerable to sound. They're also exceedingly vulnerable to any other form of disruption that then cause a head trauma. So it's not unusual when individuals have a jaw fracture, a mandibular fracture, maxillary fracture, that very often you'll see secondary symptoms occurring as a consequence of inflammation. I bring that to you simply to tell you that these are exceedingly small structures that are exceedingly vulnerable to a variety of different injuries and insults. Moreover, take a look at the structure of the inner ear. The inner ear provides a mechanism by which a variety of different pulse stimuli can be amplified. Now, if we're looking at where damage can occur, particularly with regard to hearing loss, we're mostly looking at this larger organ here called the cochlea. It's a semi-stiff organ, there's fluid in the middle, and we know that various types of auditory stimuli can disrupt the cochlea and its function, shear the hair cells, induce damage. You would see hearing loss with that. Next slide, please. What types of pathologies would you see? You'd see inflammation, both locally and then more distally. You'd see hair cell damage and hair cell death. These are the organs, for example, in the cochlea that are sensitive to disruptions of the membrane that then transmit and transduce the necessary stimuli for hearing. You would see membrane scarring in any of the membranes that were affected, and you begin to see neurological damage. And realistically, we know that we begin to see neurological damage as a consequence of two things. Number one, that the nerve itself is directly damaged because of some insult to the nerve. Or number two, we then begin to see is if you're damaging the sensory organs of the inner ear, you're seeing changes due to what's called excitotoxicity of the nerve. In other words, you're overstimulating that area of the inner ear. You're hyperstimulating the nerve. As the nerve becomes hyperstimulated, you then see a disruption of neurological calcium. And with a disruption of calcium, you then get something called excitotoxicity. Once that nerve becomes excitotoxic, characteristically, you begin to see changes occurring upstream. This is just basic neuropathology. Next, please. What type of things can do this? Well, again, a host of drugs could do these types of things, but we have to rule these out because we're not seeing drug-like effects, number one. Number two, we didn't see a constellation of signs and symptoms from these individuals that would be suggestive of some type of toxicology. And number three, the long-term effects really do not match what you would tend to see with either cisplatin or organic toxins. So as a consequence of that, we can rule this out. Some of the early hypotheses were, well, perhaps these individuals were exposed to one or more of these compounds, either directly or indirectly. Is it possible? Yes, it is possible. Might this have been a beta test where there was some priming or synergistic effect where individuals were exposed to low doses of these drugs? Yes, but these drugs were non-recoverable as well. Moreover, there didn't seem to be any other physiological signs that would suggest that these individuals received a high enough dose of these drugs to do the job. So we can rule these out. Next, please. What about sonic devices and or electromagnetic pulse and microwave devices? Well, there's a number of different things that could be done here. Realistically, what you see is either pulsatile or tonic delivery of either a sound pulse, particularly a hypersonic pulse, that would begin in the subsonic, then translate through the sonic and into the hypersonic range, and or you can engage some type of electromagnetic pulse, microwave pulsing, that could then affect the symptom in a very similar way, these signs and symptoms in very similar ways. You would get overstimulation of hair cells, clearly with any type of sonic delivery. You would get hair cell fatigue, breakage, and death. You would get scarring and denervation. But you would also see that if in fact it was a hypersonic pulse and or an electromagnetic pulse, you would then begin to cause cavitation in anything that has a fluid medium in it, which would include any one of the vulnerable organs of the inner ear, the cochlea included, but most notably, those that would concentrate this type of an energy pulse most directly. In other words, an acoustic or an electromagnetic lens. Are there structures of the inner ear that could do this? Next slide, please. The auditory features you would see, if it were just limited to the auditory system, would be these. However, this was not noted, as you saw in the earlier data. We're ruling out the idea that this was just an auditory assault. Next slide, please. So, if you're going to engage the diagnosis for this, and you're thinking, well, could there have been somebody with focused energy that would then produce the signs and symptoms that we're seeing in these individuals with the statistical significance as was demonstrated here, what might be the viability to do such a thing? Well, you heard that. Audiological testing suggested that indeed these individuals were exposed to something, but there was no long-term audiological or hearing changes. Pharmacological or toxicological recovery early on did not demonstrate that there was in fact any toxic substances or pharmacological poisoning. Cochlear imaging is difficult to do. Biopsy and forensic anatomy can certainly be done after the fact, but your most reliable tests are those that are used in neurosensory defect. Those tests that, as you saw earlier, will determine the function of those nervous systems that are involved in vestibular apparatus, balance, orientation, and position. And in fact, that's exactly what we saw. However, there also seemed to be some mild cognitive changes that were initially somewhat high and then tapered off, and then some that were a little more progressive and that were more persistent. Is it possible, as you heard earlier, that the primary effect was localized to the inner ear and you're seeing secondary effects, what we call sequelae, where the individual's levels of cognition and emotional challenge were then disrupted by the fact that they were highly vertiginous? Yes, absolutely. I mean, look, in a previous life, I flew airplanes for a living. And I got to tell you, I mean, one of the things that happens if you put individuals in a spin or an unusual attitude, it's exceedingly disorienting. Pilots and aircrew are trained to be able to function cognitively and with emotional stability in unusual environments that disrupt their positional sense. You recognize that. One of the most curious phenomena is when an individual is exposed to either spinning or tumbling, very often what you'll find is cognitive deficits that will persist for several minutes to hours after that exposure. The longer the exposure, the longer the cognitive deficits occur. What type of cognitive deficits? Most notably with regard to information transfer, information assimilation and synthesis, and the ability to then process information in a proactive way. And if you think about it, it almost makes sense. As you heard earlier from Dr. Hofer, it obtains. The issue here is simple. If I have to concentrate very, very strongly on orienting my environment to what is up and what is moving around, it becomes exceedingly difficult to do anything else. I can tell you that one of the things we use very often is something called a Barani chair. We'll put an individual in a spinning chair and then we'll ask them to do various tasks, both during the spin and after the spin. And they become so disoriented as a consequence of a loss of their vestibular senses and their positional upright and or positional surround that their cognitive capabilities seem to be grossly, grossly impacted, almost to the point that you're now seeing this is a full cognitive defect. Now clearly, when everything returns back to normal for these individuals, the cognitive defect then tapers, it diffuses or damps over time. But you do see similar phenomena with regard to cognitive blunting and cognitive defects in individuals who have profound Meniere's disease, which is an inflammation of the inner ear that then causes vestibular and semicircular disruption. Not only are these individuals positionally disrupted with vertiginous defect and dizziness, but they're also cognitively disrupted because the ability to process information, inclusive of things like upright orientation, interactions with others, then induces, as the neuroscientist Antonio Damasio says, a feeling of what happens. It is anxiogenic. It produces anxiety. If you've ever been dizzy, if you've ever had vertigo, you know that this is a very unsettling experience. And the phenomenon of that itself can be cognitively blocking. So could this be focused to the inner ear as a primary pathology that then causes secondary reactive or manifest changes in individuals' ability to process and engage cognitive information, transfer, and capability? Yes, certainly it could. But could it be more? Could it be that in fact you are also seeing an indirect or direct effect on the brain itself? Next, please. This is the idea of targeting the brain by accessing the periphery. Is it possible that what we're seeing here is not only a form of traumatic neurological injury to the ear, but a communicating neurological injury that was then able to evoke indirect or direct effects on the brain? How might that happen? Well, again, there are a number of different things that can do this. We've talked about a variety of different pharmacological agents that can co-present with some initial ototoxic or otopathologic effects, but realistically are working more in the central nervous system. But once again, we can rule these out. The reason being is we're not seeing the recovery of these agents in blood, lymph, cerebrospinal fluid, nor are we seeing the constellation of effects in the brain that would be reflective and indicative of this type of pharmacotoxicology. However, if we then focus more on the devices, there are a number of different things that could work on the brain directly and or affect the brain indirectly by working through one or more of the sensory portals. These include sonic generators, electromagnetic pulse generators, and although not necessarily pertinent to this discussion, something I do want to bring to your attention is nanoparticulate matter. And this is becoming increasingly a problem because, as Jen Snow and I are working on, this is now aerosolizable. The idea of aerosolizable nanobots has become a reality. So the idea of being able to utilize nanoparticulate matter as a neuroweapon now has become, in fact, real. What are the possible mechanisms of effect whereby you could get an indirect or direct action into what's called the supratentorial space, the space above the tentorial membrane, essentially the brain? Well, I think one thing that becomes exceedingly important to understand is that the brain is bathed in fluid. This is called cerebrospinal fluid. The brain is protected by a set of membranes called the meninges, and the meninges are basically threefold. The outermost and the most durable is called the dura mater. There's an in-between membrane that looks very much like the articulations of a spider web, and in fact it's called the arachnoidal membrane, and it is filled with fluid called subarachnoidal fluid. And then this interfaces directly with the surface of the brain, which is called the pia mater, the dear mother, literally. That layer right on top of the brain is very, very thin. The area of the subarachnoidal space is also a very richly vascular area. So what you now have is blood vessels that are interfacing with a fluid space existing in this kind of padded zone that looks like a spider web. So that particular structure itself might lend itself to some type of pressure damage and or cavitation damage if we're looking at the meninges. But it's pretty hard to get those kind of waves at that level of effect through the skull. But what happens if you didn't have to go through the skull? What if you could go in the side door? What if you could create a pressure wave that was amplified through peripheral structures that could then be communicated directly up into the brain? Essentially what you're doing is now you don't have to storm the castle to go through the walls. You can literally sneak through the side doors and then go up to the parapets. Let's go back to the inner ear. This is the inner ear. This is the brain. One more time. This is the inner ear. This is the brain. They live right next door to each other. They communicate. They communicate primarily through this region here. And this region here is called the ductus reunions, and this area here where there's an actual communication that goes from the inner ear space that contains fluid called perilymph into the brain is called the cochlear aqueduct. It is an aqueduct, but what I want you to take a look at is the size differential between this fairly large vestibular space, what we basically call here as the foraminal area, the opening area, sometimes referred to as the foyer, and the brain space. See the tube? This tube essentially works as a venturi. It communicates fluid between these two spaces. One of the things we worry about, for example, for an inner ear infection is the communication of that infection into the brain space that then would produce a meningitis. But if we create a pressure wave here, we can disrupt the internal structures in two ways. Number one, primarily by amplifying it through the venturi effects, creating cavitation in this structure here called the ductus reunions, which then affects the saccule ampullus here, in the utriculus, and or by then creating an effect that would then communicate upward into the brain space by creating a cavitational wave that goes up through the cochlear aqueduct directly into the cerebrospinal fluid. Now recall, the cerebrospinal fluid bathes the brain. So what you would tend to see is injuries that occur in and around the space beginning here that could then cause a more disruptive effect as you actually disrupt the flow of this fluid. This fluid moves. Any cavitation in this fluid is going to be disruptive, and it can create something which is known as a communicating hydrocephalus. So now what's happening is you're actually getting a change in the level of the fluid because of bubble expansion, bubble collapse. This continues to communicate. It doesn't disrupt the flow of that fluid, but it can produce neurological sequelae, both short-term and long-term. The other thing that that can then do is that can produce a lot of changes in the way the brain resorbs its blood flow, because this particular mechanism also affects the way blood is exchanged between the brain space and the vascular space. But the vascular space is also a portal by which peripheral disruption can then lead to central disruption. Next slide, please. So clearly, if we're looking at the paralymphatics, we can see that, once again, disruption of the paralymphatics, as we said earlier, can communicate into the brain space. It can also communicate up here into the subarachnoidal space, because we know that the paralymph will communicate with the CSF via that particular aqueduct. But once again, we have blood vessels that are embedded within this subarachnoidal membrane that then interface directly with the substance of the brain. If we disrupt that fluid around the brain, could we then create a disruptive pressure wave by cavitation into these blood vessels that would then be communicated into the brain space by both the paralymphatic CSF communication and the blood space? Yes, we can. These things are essentially talking together. Next slide. So if we look at these communications, what we can see is that any type of communication here into the subarachnoid space is capable of inducing a variable pressure wave, a cavitation wave, inclusive of cavitation damage, at a variety of different brain locales. We know that one of the things that this can then do is that can actually disrupt the integrity of the tissue, because you're now increasing two things. Number one, localized pressure, which then actually creates a traumatic event, which can then lead to axonal shearing, and vascular effects, which can then disrupt the blood flow to the brain. Disrupted blood flow to the brain can then lead to microhemorrhagic infarcts, small level blood flow disruption, small areas of necrosis in the brain, and this would then be more long-term. So clearly, one way we could affect the brain through the inner ear is through the fluid medium that occurs via the inner ear directly to the subarachnoid affecting the fluid medium that surrounds the brain and thereby causing a disruption to the brain structure directly. But we can also affect the blood, and there's a number of different ways we can affect the blood. Certainly, we can engage the inner ear, and most of the pathology we're seeing here with this embassy encephalopathy would suggest that the inner ear provides for us an acoustic or some other form of energetic lens. This is going to concentrate this type of information, create a disruption primarily in the vestibular area in and around the foyer that would then affect the saccule and the ampullus. This would then disrupt the function of the inner ear. This could produce a cognitive constellation, but at the same time could have a secondary disruptive effect where it's now creating a cavitation wave that spreads throughout the paralymphatic fluid, communicates via Venturi effect up into the cerebrospinal fluid space, disrupts the flow of the cerebrospinal fluid in the subarachnoidal space, and thereby can also disrupt the vasculature. But could you disrupt the vasculature directly? Could you incur cavitation changes in some area of the vasculature that's going to affect both the inner ear and the brain? Oh, yes, you can. This is the area in and around the inner ear. And what we can see is that there is a direct concentration of blood vessels. Once again, take a look at the upper left-hand portion of your slide. This shows the arterial supply to the inner ear, the utricle and the saccule. This is supplied by the anterior vestibular artery, which forms a direct connection to the basilar artery, which then communicates to the cerebral arteries, most notably the middle cerebral artery. The middle cerebral artery branches up into the brain and has what's called here this lacunar effect. In other words, there are these deep penetrating arteries that go into the brain space. These are exceedingly small vessels, and the concentration of pressure within these vessels is exceedingly important to maintain a variety of neurological responses and cerebrovascular responses. These things will change as a consequence of local pressure, and they'll alter the blood flow to maintain stable pressures across the brain space. The brain is highly vulnerable to these types of things. But if you disrupt the flow of arterial blood, you're going to get two things. Number one, you get a compensatory arterial response, and you're going to see changes in perfusion that will occur on the vascular side. If this occurs as a consequence of bubbles, which you're essentially producing here is microemboli. Can the microemboli lodge here in these lacunar vessels to create lacunar infarcts, microstrokes? Yes, indeed they can. Can you get disruption of the brain space directly by disrupting the arachnoidal membrane, by disrupting the fluid that exists in the arachnoidal membrane, by disrupting the fluid of the paralymph in the ear? Yes, you can. Can you do both at the same time? You betcha. What would the effect be? Well, clearly, if you're disrupting the inner ear directly by affecting the foyer, by affecting the utricle and the saccule, by virtue of a pressure wave, then creates some type of cavitation within those structures that are fluid-filled structures, you're going to disrupt otolithic effects and you're going to get a change in the balance organs and balance function. Could that lead to problems with regard to cognitive processing? Absolutely. But based upon the structure of the inner ear, could you also then begin to cause neurological changes and neurological damage? Yes, that's a possibility as well. You could certainly begin to cause degenerative changes at the innervation of the inner ear that could communicate along the cranial nerves to then have a neurodegenerative change. Is this easy to determine? Not necessarily, but certainly it could be done by virtue of certain types of imaging and certain types of nerve conduction velocity testing. But what if you didn't have to affect the nerve itself and you can get directly into the brain? The same pressure wave that would affect the utriculus and the saccule could indeed create a pressure wave with inside that foyer that would affect two components that would directly and indirectly assess the brain. The first direct effect being the communication through the perilymph of cavitation disruptions that then enter through the cochlear aqueduct to perfuse the subarachnoidal space and cause a disruption in cerebrospinal fluid. And the second, which would be a disruption of the vasculature here in the arterial blood supply that would then communicate back to the basilar artery and communicate up with cavitation and the blood flow to the brain. So what you see here is converging pathologic effects, disruptive pathologic effects. Next slide, please. How would we look to assess these types of things? You've already heard this. I'm not going to repeat the information. Dr. Hoffer's group did a wonderful job in neurocognitive testing, neuroimaging. Clearly, if you wanted to look a little more deeply, you'd have to take a look at some of the forensic anatomy upon biopsy, necropsy. But you could also model some of this work in vivo, in vitro, and with computer simulations, which becomes probably the most accurate way to take some simulacrum in a phantom or in some other type of situation that would then model what these effects would be on the mammalian ear and on the mammalian brain. Of course, for that, our next speaker, Dr. Balaban, will discuss some of the work that he's done to empirically demonstrate what these findings not only are, but what they could be based upon not only a type of image we see here, but the type of image that we would then see if we were to increase the frequency or change some of the electromagnetic pulsing. Next slide, please. So, based upon that, what's the take-home messages I have for you? Like anything else, let's go through a process of elimination. We have to go about this somewhat deductively. In other words, we have a set of individuals who've suffered these particular constellation of signs and symptoms, and we recognize that from that, these are the things we're seeing. What types of changes could we be seeing in the peripheral and central organs, neurosensory organs, and in fact the brain, that might be indicative of this, and what could do it? Is it possible that drugs alone could have done that? Well, early on in our discussion, we ruled that out. Is it possible that ultrasonics could do this? Yes, this is very likely and highly probable. Is it possible that electromagnetic pulsing, microwave pulsing, in some way could do that? Very possible, highly probable. Is it also possible there may be some combinatory approach, a beta test, if you will, to see if we give drug first at a low dose or ultrasonics at a low dose coupled with some type of electromagnetic pulse microwave dosing, in some combinatory form, could these be worked? Quite possible with very positive explanatory value. In other words, if someone put a gun in my ear and said, which one do you think is going to produce this constellation of effects that we saw in those individuals who were most affected not only in Cuba, but more recently in China, I would tend to think that what you're probably finding is this last one. Whether or not drugs or some other form of pharmacotoxicologic agent we use, I think remains dubious, but certainly there are devices that are widely available that we also know have been dedicated activities in the neuroweapon space by a variety of nation states that would be capable of doing just this type of thing. The inner ear provides a locus, a forum, for this to then be conducted in such a way to manifest these effects, but it's not the inner ear alone. It could occur through the sinuses, both the ethmoid and the sphenoid sinuses. It could occur through the hard palate of the mouth. Any one of the vulnerable amplifying spaces of the head could do it, and certainly what becomes important is how such a weapon could then be focused and utilized in those ways to be able to create this effect. Might it be, once again, that this was something that was serendipitous, stochastic, that this was some type of vermin-protecting agent or device that was simply in those rooms to which these individuals were then suspect? Perhaps. Is that likely? Not very. The reason for that would be that many others would have these signs and symptoms, number one. Number two, there would be some engineering artifact that would then be attributable. Here's the device, this is what it was being used for, and there would be an attribution or custodial record for that. Absent that, once again, by virtue of implication, this is intentional, this is directed, and this seems to be a beta test of some type of a viable neuroweapon that utilizes one or more of these modalities for its effect. Next slide, please. That's all I have for you. Clearly, what I'd like to leave you with is speculation. Speculation based upon the facts of the case, speculation based upon what we know about the weaponology, or at least the deviceology, speculation about what we know about what the pathology is and could be, and how this would work. So what I'm asking you to do is something quite simple. Take the facts of the case based upon the findings that were presented to you by Dr. Hoffer. I want you to take the level of possibility and probability in terms of what the viable structures are that could communicate such effects in real life terms, and then pair that, if you will, to our next set of speakers who will not only talk about what the empirical findings are that could reproduce this in a modeled scenario, but how this could also be leveraged geopolitically with regard to the viability of an increasing capability, confidence, and consideration in neuroweaponology. Thank you.
I'd first like to thank the organizers and everyone here for this kind invitation to speak, so I can share some of the ideas that we have in pursuing, looking at some of the mechanistic bases for how acoustic and or radio frequency exposures might affect the inner ear and the brain. The work that I'm speaking about is a follow-up. We've known about energy exposures for some time. Noise exposure, for example, is one issue, and has been a major issue for hearing loss with noise exposure in military environments. And in fact, the work I'll be speaking about is supported initially by the Office of Naval Research. It's noise-induced hearing loss portfolio. And the program officer, Kurt Yankaskis, unfortunately could not be with us today, but Kurt deserves a real shout out for being right at the tip of the spear on this. And really, he's been along with us working from the very earliest time. We called him up when we heard about the very earliest exposures in Cuba, and has been a partner with us fully. And I just wanted to acknowledge this at this point. His program, and you'll see some of that, you see some of the spirit of this through through the talks that we've had so far, spans from looking at what are the noise sources, is a systems approach, what are factors that lead to human susceptibility to it, prevention and treatment, and how do we design personal protective equipment. And what you'll see are the first attempts to bring this sort of approach into the Code 34 program at ONR. Now, the scenario behind all this that we're discussing, of course, is the type of exposures that we've heard about that we're seeing in Cuba. Next slide, please. And we've already heard the other speakers, Dr. Hoffer and Dr. Giordano, refer to the fact there could be a number of potential energy sources. We know something happened to people, but we don't know what did it. So what I'm going to do today is go through some of these possibilities and look at it from the perspective of sources. One of the sources are hypersonic sound, including LRAD-type devices or that type of technology, pulsed radio frequency. There could be pulsed laser source, or there could also be ultrasound, such as their new photoacoustic devices with technology that are very small but actually very powerful and could be used in certain frameworks for it. And the focus of the ONR work, actually the title of it is Waveguide, Resonance, and Cavitation Properties of Intracranial Contents. So that gives you sort of a picture of where I'm coming from. The question is, if people are being exposed to different kinds of directed energy, what's receiving it? What's amplifying it? What are the vulnerabilities inside the head and other parts of the body? We don't know a lot about that now, but the question, if we're taking a look at these kinds of mechanisms, at the wave transmission, resonance, and cavitation properties, this is possibly a way that you could get additive effects from many of these modalities of energy delivered simultaneously to individuals. Now, so what I'm going to do is sort of go through three parts. I'm going to go through three general parts here and give an overview of each of them. The first is to take a look at research done, published research from the 1960s through 1990s that deal a little bit with ultrasound and radio frequency effects on inner ear and on brain. And we'll just consider this. There's a lot of work that's been done, actually. The work that's done, I'm sampling from the papers, but this gives us a proof of concept for how to proceed. We don't have to start from square one. There was good work that was done before, funded by DOD, among other sources, DOD. And the point here that we've made, too, I want to stress here, that let's view, when we're talking about hearing and hearing injuries or sound injuries, consider the saccule and utricle to be part of it. The vestibular evoked myogenic response potential that Dr. Hoffer talked about is recorded by playing a loud sound in the ear. The saccule and utricle sense linear accelerations and will also be sensitive to sound. I will then go in and discuss a little bit, we'll go through just to show you some of the COTS devices that are currently available for ultrasound and for radio frequency application. They're used for sound delivery by modulating the ultrasound, but they're also used for pest control. And I'll show you their wide availability. Technologies out there, and in fact, could be re-engineered and in a fairly small form factor to be just placed in somebody's room. Finally, what I'll go through is illustrate some follow-up on work that we've done with data that we hadn't previously discussed from the individuals who were affected from Havana, looking at an eye movement-based test that can distinguish them with 90% overall accuracy from normal people and people with an acute mild traumatic brain injury. So this is the first portion I'll speak about, are some of the intracranial waveguide resonance and cavitation literature. And my colleagues, Jeff Vipperman is a professor of mechanical engineering at the University of Pittsburgh. George Klinzing is professor emeritus of chemical engineering with expertise in cavitation related to pneumatic conveyance, and 2 graduate students working with us, Brandon Salzman and Scott Mang. Next slide, please. So if we take a look at biological effects of directed energy, we all know that directed energy can affect, we can have various kinds of neurosensory symptoms and signs, and we have examples. If you take a look just in the occupational safety literature, the literature around introducing ultrasound into different industrial processes, and also ultrasonic imaging. There's a large literature talking about safety and from occupational environmental exposures, and also untoward symptoms that would come up, balance, hearing loss, and features like that. So one of the things that we're doing right now is looking to characterize the waveguide resonance and cavitation features of cranial contents. Dr. Giordano kindly went over the basis for all this material. Blood vessels, as he showed you, are surrounded, major blood vessels are surrounded by interstitial fluid, brain fluid, which is confluent with fluid in the subarachnoid space, and look like coaxial waveguides in the Virchow-Robin spaces. Next feature, we have the ventricles and cisternal system, which he mentioned. Again, fluid-filled, possibly resonant possible chambers. We have the inner ear, and we also have the air spaces. We have our sinuses, we have our middle ear cavity, all of which can act as amplifiers and can act through cavitation as well as through different acoustic resonances of the structures. Now, this is a simulation, we'll play it in a moment. What we'll be presenting is a multiple sine wave. So sine waves being presented this is a finite element model of the human head. The publication references here, Dr. Vipperman and I did this. It contains hard and soft tissues. Brain is modeled with different white matter and gray matter constituents to it. Blood vessels are not included, but meninges are included in it. So I want to say right off, models, as we discussed before, are a nice way to think, but the joke is you can sometimes tell a person how a spherical horse runs with a model, depending on if you put legs on the model. So this doesn't have all the legs, but I think this can show us some principles. Would you play the model? Would you play the simulation, please? So these are 3 sine waves are being played to this from externally, and they are at 10, 10.166, and 10.322 kilohertz. So this is a signal, as if you present a signal. Let's play it again, please. So what you'll see is a beginning in the ear, and then you notice this is resonance in the subarachnoid space, moving along that and centering right over here, over the temporal region. We saw the middle cerebral artery is a major artery with everything conveying along that area. So one of the things we're seeing here, and next slide please, gives us, now with this one, it's the same model, but instead of having 3 different signs, we simply put in pseudo-random noise in the ultrasound level above 10 kilohertz. Next slide. Should we hit that? Let's play that. So you see the same pattern when we're working with incident energy in that area is producing resonances. Resonances over certain areas beginning in the ear and moving out into the subarachnoid space in a model. Okay. Let's store that away and remember this area as we look forward through some of the literature. Now, the classic idea of acoustic stimuli impinging on us, we think about the ear and the cochlea as a transducer. The classic work on this, the Nobel work of Bonvekischi, and cochlear transmission. In fact, he was funded for a while for some of this work by Office of Naval Research historically back in the early 1960s. The mechanical resonance of the basilar membrane is one of the features, as Dr. Giordano mentioned. The peak resonance varies from high frequencies at the cochlear base to low frequencies at the cochlear apex. So if I have high frequency ultrasound input in, where is it affecting you? Right down at the base. What's right next to the base? The otolith organs, your organs of balance. And the activation of the sensory cells with the relay through the, next slide please, I can show you this. Okay, so what happens is that the basilar membrane, here is a cross section through a human ear. You can see the basal, middle, and apical turns of the cochlea. Here is the hearing apparatus. And if you unwrap it like this from the base to the apex, this just shows that when sound is incident at a certain level, it sets up a standing wave at a certain frequency based on the resonance of this membrane. This resonance is like a resonating beam, like a xylophone, and it's going to resonate. And at the point where it's resonating, these hair cells, which are on the surface of the cochlea, have their tips deformed, and they transduce that sound. That's how the hearing system normally works. Now, what you'll notice is off on the lateral edge here, I'll walk over here where I can point to it. You'll see there's a structure called the stria vascularis. We'll get to that in just a moment. Next slide, please. So here, this just shows us that when we come to the base of the cochlea, the hook portion of the cochlea, which is excited by extremely high frequency sound, sits in very close proximity to the organs of balance, the saccule and the utricle. So, take-home message, you're in a vulnerable spot, guys. They're sitting right there. Now, another very interesting area that's come on when we started thinking about sound exposure, I realized that there was an area in the literature which we're going to go through right now. The stria vascularis is one of the regions that produces, it's important for recycling the endolymph and perilymph. Now, endolymph in the ear has a very high potassium content, and it's important that it be 80 millivolt, have an 80 millivolt difference with respect to the perilymph and CSF. And this is a highly vascular structure that's really important for maintaining that ionic difference, because potassium ions are what drive the hearing process. You'll lose that potential difference, you'll lose that potassium, that ionic differential, you're going to impair hearing and you're going to impair balance. But the stria vascularis has also in it a very intricate network. So here's the basilar membrane, and you can see the stria vascularis. Arteries enter from the top, it percolates through this system and comes out venules at the bottom. And it's, a methacrylate cast of it is shown on the other side. So what it actually looks like, if you think about two pieces of chain link fence, a two-layer chain link fence of blood vessels, a network, vessel coming in from the top, vessels exiting from the bottom. And the flow in these vessels, we know their dimensions, is non-pulsatile. What we have set up here is something that could be a phased array cavitation amplifier. Okay? I'll leave it at that point. That's one of the things that we're looking at right now. This is a structure inside the ear, and in fact, it's tightly packed with blood vessels, which can act as cavitation sites when exposed to sound. And next slide, please. And in fact, it differs down in the portion of the base of the cochlea. There's a focusing kind, at least in rodents where it's been looked at. It looks almost like a parabolic reflector pointing in down at that area, suggesting there might be differential amplification. And so what this may do, actually, we'd suggest, is maybe a cavitation type of an amplifier. Now, how might this work? This is a picture from Apfel's classic work on acoustic cavitation from a book on ultrasonics in 1981. And this is just showing a frequency spectrum of output when you subject water to a 10 kilohertz acoustic stimulus. And you'll notice what you get out is a very characteristic spectrum. At relatively low intensities, you basically get a whole bunch of harmonics kicking right out. Looks like a comb coming out. You increase it a little bit, you start to get half harmonics. Increase it a bit more, that's what you get out. What you're effectively doing is taking one frequency in and you're amplifying over a broad range. By the way, this gives us an acoustic signature to look for cavitation now in animal exploration using small hydrophones. And just to point out, okay, at the time when we're worried about ultrasound safety for imaging, a lot of work was done looking at blood, and they were going up in the megahertz range because they were interested in imaging. You work down in this range. Needless to say, we have good enough data to go on to start doing modeling and validation studies from the previous literature. So one of the suggestions we have here is incidence sound. We want to take a look and see how does incidence sound in the ear. Might this be a mechanism in real hearing also? So there are literature, in fact, which give us the basis for looking at it. You can see considerable pressure differences, actually a much higher pressure difference we record inside the cochlea. Pretty high sound pressure, even to regular sound coming in through the normal transduction mechanisms. And what we can do here is we have the potential to measure directly in these cases. Next slide, please. And this just shows you some intracochlear recordings that were done of pressure waves. And just to show you this can be done, this has been done, and you produce you see an amplification in the sound level inside the cochlea over what we have coming in incident in the air. And theoretical calculations suggest that it exceeds by several orders of magnitude cavitation thresholds for the liquids we're talking about here. Now when I was thinking about this, one of the good things or bad things about having a memory and being a professor and having read literature for years is I remembered this paper written by, from Fred Nuttall's lab when he was at the University of Michigan years ago, some of Quirk's work, and this was published in 1991. And what they did was visualize, they put a fluorescent tracer in the blood, and they are visualizing with a camera the lateral wall. They're looking at the vessels in the stria vascularis. So imagine you cut away the side of the cochlea and you're looking in there and watching the stria vascularis as you play loud sound. And what they observed was, under control conditions, the blood's flowing slowly through. You could see the red blood cells moving through. When they played about 110 decibel sound, you notice the flow. This blood vessel didn't collapse. It just looks like a void space. Remember, oxygen and nitrogen are dissolved in the blood. One of the possibilities is we actually have and compression, decompression does what? We know about this from underwater environments and aviation environments, right? You can get decompression sickness. You can get local bubbles or emboli of different gases. They couldn't say what it was, but again, it recovered when they turned this off, suggesting that there are sound-induced events affecting the blood flow and possibly affecting the partitioning of gases in the blood. So we come up with an integrated view that cavitation of water and blood can appear that they can occur within audible and outside the audible range of frequencies of acoustic stimulation of the cochlea. Pressures come up into that area, and dissolved gas may form bubbles. Hypothesis, okay? A possible mechanism, highly plausible based on existing data. Now what I'd like to do is shift to the Frey effect, as it's called. In fact, I spoke with Alan Frey a couple of weeks ago. He's working as a consultant in the Washington area still, and remembers this well. It's been very useful. We'll be back in contact with him. But he was telling me how he went to a meeting and someone said, you can hear, someone working with radar said, I can hear the radar pulses. He was skeptical, so he went up to a radar facility with the guy. They played it at him, and yes, indeed, he could hear it. And so this is the first paper describing it from Aerospace Medicine in December 1961. Next slide, please. And what they did, looking at this in more detail, they went up and basically with all the different kinds of radar emitters they could get their hands on easily, they played different pulses at each other, and they found that they were indeed audible and that they could block it by putting a piece of screen over this part of their head. And I asked him, how'd you figure that out? And he says, oh, I took a piece of copper screening up with me that I had grounded, and I was just moving it around. And he said, you put it there, it would block it. Looks like a familiar spot, doesn't it? Coincidence, maybe. And so of course, there's a small but very robust literature showing that human perception will vary depending upon the integrated power delivered, depending upon looking at parameters that could underlie this perception. And in fact, this was pursued, some work supported by Department of Defense, Office of Naval Research, looking at impulse exposures to microwave energy. In this case, they put a little electrode on the round window membrane so you could record cochlear potential changes, and played microwave pulses, roughly 900 megahertz range pulses to guinea pigs. And they recorded an ultrasonic emission, meaning that the ear was emitting at that level and was excited at that level, and in fact ringing at that level. Next slide, please. And because this was fundamental work, I'll show you some of just to get a feeling for their original data. This is recording when there's a click, either initially positive or initially negative. This is what you'll call the microphonic potential that comes out from that. Here is when it was played on the same time base, when they played a single radar click. And this is magnified about 100-fold in terms of the time base, and you can see how it's ringing. What they reported show you the traces that when they went with pulses ranging, you can see the different total energy delivery per kilogram that came out of this. But if you take a look at the range in times from 1 microsecond to 10 microseconds, you got a resonance out of the ear. Okay? What is it? Next slide, please. They really don't know, but there was some work out of the former Soviet Union where they did something I'd be reluctant to do nowadays. They took a big old horn antenna and stuck it right up on the side of the head of people, and they asked the question, at what frequency of pulse repetition do people hear radars? They did an audiogram for radar pulses, and they found in the 10 to 15 kilohertz pulse repetition range a maximum sensitivity of people for it. Now, other work, I'm breezing, these are not all the papers, I'm picking just a few illustrative cases. There was work done recording from neurons in both the auditory nerve and here from the cochlear nucleus that's done in a cat. And they basically showed that cells with acoustic responsiveness, typical acoustic responses, also could respond to radio frequency pulses. So the ability of radio frequency to affect the nervous system through some mechanisms is real. Next slide, please. And in fact, here's one of my favorites, even though this was published in 1988. They took a cat and put a series of hydrophones into the cerebrospinal fluid and played radar pulses from the back of the head of the animal. And this is a power spectrum coming out. You notice how it looks like a comb? They had no idea what mechanism was there. They said it's clearly propagating, but it sure looks like it could be a cavitation type of phenomenon. So we see they posited the thermoelastic response was responsible for this audibility, and we have several mechanisms that are possible for this, including effects on the saccule and utricle, and perhaps effects through intracranial blood vessels. So all of the mechanisms that Dr. Giordano spoke about are actually supported by a fairly robust older literature, and sometimes we have to just sit back and read the older literature and remember that we're standing on the backs and working on the backs of those people who did some really fine work, dedicated people, and many of them DoD-related researchers at that time. So this just reminds us of the location of the otolith organs. You see it's hanging loose in close proximity to the base of the cochlea, where the frequencies we're talking about would be expected to create maximum resonance. Part 2. I'd like to point out that there's some very small COTS devices that with modification could deliver this if planted in someone's room. Many of these in principle could be put in something like a heating duct, an HVAC duct, could even sit in a thermostat. and what it would look like in your room replaced there. Here's one device, and I listed. I urge you to look up this myskunkworks.net. They tell you that they have a power amplifier, and here, can be used as a phaser pain field generator if you use it with our sweep frequency IC, or for experimenting with an LRAD sonic weapon. There it is, sitting right out there on the internet, available for anyone to buy with PayPal. Next slide, please. And this shows all of their ultrasound products that they sell. Experiment with your own sonic weapon, guys, okay? This is out of the bag. It's Pandora's box is open. This is from a major retailer, and this shows you what they sell for pest control, the latest in pesticide-free pest control. Ultrasound, ultrasound plus electromagnetic pulse, ultrasound, all of these advanced pest repellents. Guess what? They're being produced at a lower range than we need to see the effects we want, but they're being stuck by people put by people in their own houses. Suppose someone decides to soup it up and give you the next super duper one. Are we looking at a public health risk? Maybe. Here's one of my favorites, okay? I woke up one morning to news radio, and they had this, make your house pest free. They were describing this, I looked it up. They're pumping electromagnetic pulses through the wiring of your house to eliminate pests, okay? Guess what? Anybody can, okay? The technology's there, it's at a lower level. You think that an adversary couldn't very easily design something a little higher powered? Okay, it's there, it's out of the box. Now, one of the things that we've been experimenting with is a version of this device called sound laser. This is called a parametric speaker. You see a whole series of little elements there. Each one of those are piezoelectric emitters, and this is a 40 kilohertz carrier. And the way it works is you can project a beam. You could project it easily all across this room. It's about 3 feet in diameter. And if you amplitude modulate the 40 kilohertz with the whatever you want with speech or something like that, use a carrier frequency, you will hear the sound on beam. It's used in museums and other places. You walk off beam, it's gone. Sounds a lot like something we heard about, or that was described to Dr. Hoffer by some exposed individuals. And they sell a variety of devices. Next slide. And this is one of their devices that we've been working with a little bit. This it actually uses a series of commercially available ultrasonic these transducers. We can pull out the properties of each of them. You easily can, if you take off their amplifier, you easily can crank out 140 dB out of this device at a meter. And what I'd like to do here, just before we play it, here is that board, and I'm going to show you one of the first time we saw this in the lab. The graduate students are going to move the board over a cup of water and watch the cavitation on the cup of water. Please play it. We're not getting the sound, but there, see the water? That's a standoff across the interface, and it looks like we're working with it. We have high-speed cameras on the side and such, looking at this now, and it looks as if the surface tension of the water is creating nucleation sites for cavitation. So yes, we can get, with even commercially available devices, without scaling this up or anything else, just putting a little more powerful amplification on, we can get cavitation across an air gap. So now let's shift a little bit to take a look at what might have been going on in Cuba, and what I'd like to do is present some evidence of a technology that could be deployed far forward for detecting something like this. Caveat, okay? We only have those 25 people exposed as our pool to look at. So we're basing this on limited data, but I'd like to show you what we do have right now. Next slide, please. And this, again, is part of the ONR, Noise-Induced Hearing Loss Program portfolio. So we talked about these potential types of exposure. Next slide, please. And we saw that, reviewing what Dr. Hoffer presented, that we saw a high prevalence of what looked like otolith, saculonutrical-related effects in these individuals. It was more homogeneous than you see in TBI populations, and a much lower prevalence of headache. So maybe it's like a TBI, maybe it isn't. And the cognitive symptoms were more pervasive, and we saw some other elevated cognitive type of signs, like an abnormal anti-saccade test. Anti-saccade test, you're asked to look, you have a spot come on over here, you have to look in the opposite direction at the same spot. And when we're intact, we can do that. When you're, as I put it, dinged and not quite right, NQR, you have trouble doing the task. And sort of my definition of traumatic brain injury has been all along, this, I don't mean to upset some, I sort of do mean to be provocative when I say it, is you have an event that they got dinged and they're not quite right, they meet the NQR criterion. And what we try to do is quantify and specify what NQR means so we can treat them, diagnose, treat, document, and take care of these individuals. And this is just a publication. We've been hearing allusions that otolith dysfunction or ear dysfunction can affect cognitive functions. This was done with a colleague, Ashley Wackham, who's currently at the chairman at Rutgers University. And we found that we could document it in the wide range analysis of learning and memory type of tests, that there were deficits pre-surgery in people with otocapsule deficits, and when they were fixed and they were asymptomatic, they improved their performance on learning and memory tasks. So this is one of the few studies that have shown objectively that kind of a finding. So I also want to warn everybody and let you know we're not naive enough to think that if people think they heard something, it really was a sound there. Okay? We could, by activating the area of the nervous system by something other than sound, like RF, you could hear it. So we have to be very cautious in interpreting symptomatic reports, especially after people have heard from other people what they thought they were exposed to. So what I'm going to look at here now are some aspects of vergence, and these are convergent eye movements that distinguish Havana syndrome from mild TBI. Convergence eye movements, if you follow your finger going toward your nose, your eyes will converge and your pupil constrict. And this is work done with Dr. Hoffer and Dr. Levine at the University of Miami. And this is done with data that were gathered, but not as these were gathered as these are things that Dr. Hoffer recorded with the eye device, but they're not medical tests, so we analyzed them post hoc looking back at it. Okay, and the device we use is right here. It's a Neurokinetics eye portable assessment system. That's a virtual reality display. Inside it, you can analyze each eye's movement independently to better than 0.1 degree accuracy. It's fully calibrated, and it allows us to control stimuli for the people to look at. And for studying convergence eye movements, we can have spots moving, and the disparity, you'll watch them so you don't see double. We have no change in overall illumination, so we can study the convergence movement and movements of the pupil and eye without any interference of changing ambient light levels, which will affect the pupil. So we can watch the eye movements, we image the eye under infrared diode illumination, and we can track the eyes with great accuracy, as well as measure the size of the pupil, the area of the pupil. So as I mentioned before, the convergence eye movements we have, we're all familiar with. As you move your finger toward your nose, your eyes will converge so you don't see double, and your pupil constricts to increase the depth of focus. When you move away, you get the opposite effect. The eyes diverge, and the pupil will dilate. And so we took a look here at 51 normal control subjects, 18 subjects with mild TBI taken from the regular emergency rooms at University of Miami, Naval Medical Center San Diego, and Madigan Army Medical Center. So 3 different individuals people in labs were making these measurements, and 19 subjects with completed data from the Havana affected population. And so 2 tasks were done. One I call the binocular disparity, sometimes fusion task. So you're looking at the display, and at a point, they move away from each other by a small distance, about 1.5 degrees. And so you don't see double, you naturally fuse the two. We've all had that experience, we do that all the time. Then they move in the other direction toward the nose. Second one, we call it disparity, a pursuit task. They start like this, and here they move, they diverge and converge, but very slowly. And we naturally follow them, and during both tasks, you have the illusion that it's moving toward you and away from you. you're making the movement like that. And we simply record the eye and pupil movements during those tasks. This shows you from two different control subjects, one shown in green and the other shown in black, the eye movements. And you see people follow that, the spot shifting, quite well. And then these are the pupil movements going on at the same time, recorded simultaneously. And this shows you for the pursuit, the same two subjects. So you see, we follow it quite nicely and quite naturally, and you'll notice the pupil is dilating when the eyes diverge, and constricting when the eyes converge. And it's a very regular process that one can analyze with simple engineering models. Next slide, please. And in fact, this I don't mean everybody to read, basically from work done by Larry Stark and others in the 1980s, very fine work on this. We can make an engineering model and estimate parameters that describe these responses quite well. And this just shows you the model fit for a control subject for the eye movement, that's the gray line, and just modeling the pupil based on the eye movement alone as the gray model on the pupil. Does pretty well. The fits are pretty reasonable. And by the way, I found out when they put the models up, I thought, oh, I can do better than that. And I probably went through every experiment that they did in showing why you couldn't right afterwards. And then this shows you from a subject from Havana, the same kind of data. And one thing you'll notice, foreshadowing it, you notice how much larger the pupil response is? Pupil responses really are larger. Next slide, please. So this summarizes data from the step binocular fusion test. And what I plotted here is what's the amplitude of the eye movement converging or diverging from the model. And you can see that there's no difference between the Havana affected people, but the people with mild TBI, as we've seen before, have a significantly lower magnitude of those movements. And in fact, the fit, the coefficient of determination, the R-squared values, are quite high for the model fits, so there's quite high fidelity, but the people with mild TBI don't follow it so well. So their magnitude is lower for the movement, and and it's less accurate. If we take a look at the pupil constriction, how much the pupil constricts per degree of convergence eye movement, though, you'll notice there's no difference in behavior between the control and the acute TBI. But take a look, it's a more deterministic fit, interestingly enough, so maybe they don't have the other emotional effects on the pupil, but the magnitude is much greater, and that's significantly different. And we see a very similar picture for the pursuit task, except we see there that the amplitude of the eye movements is reduced for both the control, for both the TBI and the Havana exposed individuals, but when we come down and take a look, but the fidelity of fit is different, and the pupil constriction is much more active. It's hyperactive, programmed at the same time in these individuals exposed in Havana, and the same feature for the fits. So we take all these data, next slide please, and if we do a discriminant analysis with it, very simple, I've got 3 different groups. How well can I pick out, based on these test results, these different groups? And you can see we get 92% correct classification. We do we take the one-out cross-validation, we get close to 90%. These people, you get no cross-classification errors between the Havana people and the mild TBI population. This is a fieldable technology. So what we think we've shown here is, first of all, we can distinguish them objectively by performance in these kinds of tasks, these sort of binocular disparity divergence tasks. And they show an abnormal convergence and near response behavior that's distinct from what we see in garden variety concussive injuries coming into an emergency room. So what we suggest is, right now, the current technology is something that could be taken out at least to a far forward medical station and deployed to see whether people had as a first read, did people have some kind of an exposure. This technology itself, next slide please, can be miniaturized, okay? The form factor is not great now, but within less than a year, you could probably have something that could be installed on any battle helmet, on any helmet, any kind of headgear you want. Instead of having the personal computer, you simply put a processor right on the back of a custom-built camera. You can increase the sampling speed and get even more precision for picking up other kinds of eye movement deficits. This is ready for 6.4 at this particular point, and pushing forward with these features. And this is being supported, some of this, but at a slower development rate now by the ONR, Noise Induced Hearing Loss program. Finally, looking at this, I just want to say this technology and our ability to read the covariation between pupil and eye movements is potentially useful in many altered environments. OBOG type of problems that we see can probably be detected because oxygenation state changes the pupil responses. You can look at undersea hypoxia, hypercarbia in these areas, and also what's the person looking at, how are they reacting to it. We could use this in a variety of different kinds of cognitive interfaces, whether we're dealing with virtual reality or augmented reality kinds of platforms. So this is where we are at this point in time and pushing forward with it. We think we don't know what the exposure was. We're working along on that side, but at least it's interesting to see that we have, and we can distinguish between them, which is very important, which I think is going to end up being very important operationally. We want to be able to pick out people objectively, take a look at it, and so we don't just have these 25 people running down along the line that we can study out there. Thank you very much for your attention, and we'll get to questions later, I guess.
I'm going to take a look at less on the technologies, more on the capabilities, and try to answer the question of who might be interested and why, what is the upside, and for who. Next slide, please. I run a think tank, the Institute for Global Futures. We do one thing, mostly for corporations around the world and governments, to look at what are strategic readiness factors. How do we define that? What does that model look like? We look at a variety of different kinds of technologies. I'll break down 5 today, but focus on neurotechnology. And our mission really is to enhance future readiness. So I'm going to put together 2 concepts and then come back to this and reiterate it. Lack of imagination is the enemy of future readiness. And those of us who are involved in deterrence, strategic awareness, know the implications of that. Is it possible that neurotechnology could be a candidate for a new threat domain, or contributed to a new threat domain for all intents and purposes, that their only enemy might be a lack of imagination? Worldwide clients, a lot of them are in the room today. So I'd like to start out by thanking SOFWERX for inviting me, and just to suggest to you that I've been working with the community in identifying a variety of technologies over a fairly long period of time, and I'm still on this journey. Also, I'd like to just call out Dr. Giordano, who gave me an opportunity to work with him at the Center for Neurotechnology at Potomac Institute, where we started to do some of this work. So I'm going to frame out for you kind of the big picture of what neurotechnology looks like, to give you, for those who are not that aware of that. We've been focusing a bit more on the particular incident in Cuba and the analogous implications for other attacks that might have a similar signature. But really what I'm going to do is try to paint a picture of where this technology has been, where we think it's going, and also then drill down on this particular event. So this is a model that came out of some work that was supported by the National Science Foundation, NSF, and it was work that was done over the past decade to kind of consider what are the top technologies that are exponential technologies that are game changers, meaning for our civilization. That would affect everything from healthcare to defense to manufacturing. You know, what does it look like? And the top technologies we identified were nanobio, IT, and neuro. And then subsequently, I upgraded this model and added quantum as another strategic technology that would create a massive amount of opportunities. Now, every one of these 5 technology buckets has dual use. So for all intents and purposes, we focus almost exclusively at NSF in our study on converging technologies for improving human performance, but we recognized also that there was a dark side. Dual-use technology has followed us throughout. So I'll talk a little bit more about that. But just to define this so we can move on, it's the manipulation of really genes, atoms, neurons, bits, and now qubits that will shape the next likely decades, if not 100 years plus, of our civilization. And there's other ones that you can fold into this. The one I'll be focusing on talking more about is neurotechnology. Convergence of exponential technologies, certainly the rise of neurotechnology, has had a broad effect on many other areas other than just medicine. And for all intents and purposes, the one area that, quite frankly, has not been affected has been in security and defense. For all intents and purposes, we've been looking at innovations, for instance, neural nets, which are at the core of artificial intelligence, control and monitor over $1 trillion worth of financial trading, for instance. Neural modeling and technology has a massive impact on chip spaces. Can you take me back a couple slides? Right there. I want to just make a point about this. The singular scientific piece of this that we published, is a thought that I did not convey, but I just want to suggest to you. It is not just that nanotechnology, the manipulation of matter at the atomic level, or the mapping of the human genome, or the ability to be able to create a new computing platform in quantum computing is important. It's how you think about these together, nano, bio, IT, neuro, and quantum. And that's been the big aha in doing the scientific modeling work. Why? Because most of the time, and if you look at how we've organized these bodies of work, whether it's nanotechnology or neurotechnology or IT, is they're silos. You've got folks that really get computers, quite frankly, who are working, even adapting innovations, never talk to neuroscientists. Neuroscientists are not engaged with nanotechnologists, who are kind of an engineering measure. Biotechnologists who are working now, there's a few crossovers, like synthetic biology is the beginning of this convergence, but the idea we were suggesting is if we're going to create and solve big problems that are facing our nation, whether they're national security or whether healthcare in terms of disease or manufacturing futures, what do we have to do? We got to think more holistically about the systems approach to science, and here are the 5 key technologies. We could have chosen other ones, but these are the big strategic ones. So thinking about these together requires a different way of looking at science. And that implication is dramatic for where we are today with neurotechnology, but also it has to do with the breakthroughs that would need to occur in healthcare and security, and certainly in defense and other domains as well. So let me talk about the big context, therefore, okay? If you're traveling with me on this journey, right? I'm going to get to our focus. So I'm going to now kind of pivot a little bit, focusing on the trends that are associated with neurotechnology, then go after this particular event and what the implications may be. So the first is that we're all living in Moore's Law. And most of the time you think about Moore's Law, again, as you know, this was one of the founders of Intel. Basically, his hypothesis was that computer technology was doubling in power originally in 18 months. We brought that down. It's actually collapsed, so it's less than 12 months. In that same period of time, Moore said that the cost of that technology power was also being halved. So when I was at Apple Computer, we spent, it was $2,300 to bring out the first Macintosh, and it's a little black and white screen, and it 30 megahertz, and it was a box, and wow, what does $2,300 get you today? Supercomputer. Most of you carry them in your backpack, right? So we're talking now about, and no one's used this word before, Moore's Law. And you heard Dr. Balaban talk about these devices. He's absolutely right. This is not rocket science. This is all about Moore's Law. Shrinking, smaller, more powerful devices. So I'm not going to prosecute hey, maybe this is some exotic technology. Maybe it is, but maybe it actually is. Somebody hacked some pest control devices and they wove it together, and then somebody else looked at that as an example and they put something else together, right? So, if you want to cut to the end, It might be, what are the diagnostics and devices to be able to create ways to interdict and prevent this? All the science is great, but maybe they need to be devices that are stuck in every location that we want to stick them in there, and they do two things. One is they monitor and they sense, and every sensor is a small computer. They sense the inaudible range, and they end up alerting through a cloud network, the security services, if there is an intrusion, an insult that's being monitored and shows up on our grid. And the other is we actually interdict it. Now, that's the operational thing that, quite frankly, wouldn't be hard to put together, and that's an operational deployment. But before we get there, I'm going to look at some other issues as well. All right, so the other part of this Moore's law is not only every device getting smaller and more powerful and cheaper to deploy, but it has to do with the proliferation of those 5 key technologies I talked about. So it's the proliferation of nanobio IT neuro. So you heard Dr. Giordano reference nanoparticulates and nanotechnology. Again, the manipulation of matter at the atomic level. Just want to remind you the era that we live in, right? Anybody out there manipulating matter at the atomic level at home? Well, you could. You don't have to have a big lab, right? CRISPR is a technology for doing genetic engineering. You know what the skill set is? Operating a video game. We're living in an era of accelerated proliferation of 30 or more technologies, which you don't have time to prosecute today, and the implications, obviously, for security and defense and intelligence are massive, as well as they are for healthcare, manufacturing, finance, and the beat goes on. So that's the era that you're living in. Accelerated exponential technologies. I named 5, and we'll be drilling down more on neuro. Now, there's also 2 parts of neurotechnology. I'm carving that out of neuroscience to say, okay, so here is something to pay attention to. And when it comes to neurotechnology for the applications that it looks like in Cuba, and we think in China against American officials, it's likely there are 2 dimensions to neurotechnology. One is a soft dimension, which is dysfunctionality, cognitive impairment, the inability to be able to make good decisions, right? Even dizziness and health effects, but certainly cognitive dysfunctionality as a delivery, as a weapon system. Think about that. And then there's the hard dimension, soft and hard, of neurotechnology, which is rendering individuals not just dysfunctional, but inoperable or even dead. Fatality. All right? So we haven't gotten to that. But the issue of non-lethality of weaponized capabilities, non-lethal weapons that are associated with neurotechnology, that is the era that we're in. So my operating assumptions to do this work are: 1, Americans were attacked. American officials were attacked. There was a signal sent by certain parties for a purpose. We'll get into that. And the conclusion is, of course, well, why was that done? Was to demonstrate a proof of concept. We'll talk about the implications of that. And we'll get into who potentially geopolitical actors might want to accomplish that. But you could follow that logic pattern forward to be able to run that out. This is an operational deployed capability. Soft, non-lethal. The possibilities in what we call hybrid conflicts are that there is now a new weapon, a neuro weapon, a neurotechnology weapon that is now available. We have to accept that as the new reality. And we particularly have to accept it for all intents and purposes because it's already been deployed. And it was targeted and purposeful. I don't believe that it was an accident because of the cohort that was targeted. And now that we have 2 incidences that we can compare data on, we don't really need to see the data. We know that there's 2 populations that are similar. There are other friendlies that were targeted. So the assumption of accepting the deployment of a new weaponized capability is, let's get over it. Okay, we got that. Now the issues are deterrence, prevention, diagnostics. That's my operating premise. So neuro is likely a game changer, maybe. I want to now drill down, just again, this is a larger context, but there's a variety of things you don't think about that neurotechnology has an implication on, which I'm trying to point out is that it's a much larger phenomena in terms of impact domains where it's in the wild. And many of the same agents I've seen, and I mean neuro agents, these are in silico programmed bots, are now programmed on the way we model neuronal interactions and dendrites. So again, this is just a bigger phenomenon of which this is one carve out, but it's not like there's not tremendous opportunities that are going on in other areas and the implications. And we haven't even talked about also enhanced minds and the performance enhancement from neuro and cognosceuticals, which is a whole other dimension to this, which we're not getting into today. There's direct implications, the other side of what we're talking about. Also, it's had a massive impact on healthcare. We don't have time to go after all this, but if you look at the far side on the right, it's neural enhancement as a deterrence for a prevention for age-related diseases. Again, every dual-use technology will have a dark side and a light side. We're in that era now. Why? Because half of the population is at risk for Alzheimer's. The other half of the population will be caregivers or dealing with a global phenomenon, which comes from longevity and a variety of other factors, quite frankly, that we don't understand, but has to do with the aging of the brain and may have to do with insults to our civilization that we're creating, which is a whole other factor. But that's the era that we're in. There's 100 companies working to defeat aging, which have to do predominantly not so much with your bones, your organs, or even disease, which we're navigating that, have to do with cognitive dysfunctionality, decline associated. So we're in an era, you might say, where cognitive fitness is a capability that we will all need to understand better, and neurotechnology, therefore, is a deliverable in this era of cognitive fitness. One side is enhancement, longevity, health. The other side is weaponization. I want you to just put that out as a context so you understand, for those of you who are unfamiliar, what it is. Everything you ever hear about robotics, artificial intelligence, all of this is what? Converging with neurotechnology. You can't get there without that. We're building robot brains. What are they going to do? They're modeled after what? Nature. Bio-nanomimetics. Parallel phenomena, right? Not many folks understand the convergence of these factors. Remember, 5 key technologies. All right, so neuronal self-assembly. Again, we're in an era where, one of the factors of nanoscience, and I was the first private sector advisor to the interagency working group on nanotechnology. So what we did at NSF was we helped create the world revolution in nanotechnology by first investing under President Clinton and then under President Bush. We basically funded the formation of an entirely new domain, nanotechnology. But really it was to be able to say nanotechnology should be at the table with these other key technologies. Why am I talking about this? Because when you start to talk about neuronal self-assembly and nanotechnology, you're talking about the ability to be able to create an entirely new marketplace and understanding of science and drugs and other things. And the dark side of that, the dual side of that, which is weaponized capability. So that was a reference Dr. Giordano made earlier, which there is a whole other conversation we could brief on, which has to do with nano, bio, neuro. Neural reprogramming is likely the driver of or architect of and the defeat of age-related diseases and remodulating skeletal and organ combinations and the ability to be able to revitalize and rejuvenate even your brain. And again, this is stuff that sounds science fiction. It's really not, and we're getting there a lot faster, and it'll likely be delivered as a device. Okay, so I would hypothesize that neurotech is going to be a contributing factor in driving the next hybrid war, which has already started. And this is an era of, again, soft, non-lethal, moving towards something else. Think about the implications of a neurotechnology capability that could render for a decision-making command structure dysfunctionality in terms of decision-making and just distort time. I want to distort time. I want people to lose track with time. And I want to affect that part of the brain that leaders have to do that. How would that affect a battalion? How would that affect a series of negotiators for a treaty? How would that affect people? You might lose track of time and have a stress factor. Could I echolocate and deliver that signal? Could I, gentlemen? Yes. Possibilities are there. So we think about hybrid conflict as irregular forces, diplomacy, cyber attacks, economic warfare. What if this is a new contributing dimension to that? And we haven't thought about that. We're not there. And if anything, this is a wake-up call to what? That capability set. You got to think about it in terms of deterrence like that. You have to think about that differently. Why? Because we live in an era where most of our major threats have been because of the lack of imagination that it could happen. Why? Because we have most folks fighting who were in leadership fought the last war. That last war, by the way, was yesterday, not tomorrow. Thinking about the last conflict. So my suggestion is we need to think more radically about these. Again, one of the other factors of Moore's law is the accelerated velocity of innovation. Well, you could just listen to this, right? You're going back, and you're gonna brief the command that there's these pest control devices, we think that created this, this attack. I mean, it sounds. I really want to do that brief in front of Joint Chiefs, don't you? To hear them, I hear the laugh. Yeah, and it's like hearing guys hijack planes. So I just want to point out, interestingly, this is an example of a massive DOS attack in St. Louis over the past, year, massive. Someone is testing a DDoS attack on the West Coast. This is what it looks like, right? This is what it looks like. Imagine that as a neurotechnology attack. And notice also that what a botnet is, the core of a botnet is self-propagating what? It's like a virus propagating in real time. It's an activated silicon programmable neuronal agent. That's a lot of what it looks like, because once it's set in motion, what does it do? It's like Ebola for networks. I'm just trying to disrupt your thinking, think along the lines of how it's a different way of paradigm of looking at this stuff. So as I said earlier, every technology has kind of this, dual side. So fantastic futures are low-cost designer drugs, stuff that, we go after being able to do proteomic targeting for cancer cells and living cells as biofoundries. We're getting all there. At the same time, we've got hypervirulent protoviruses, genetically selective pathogens, Trojan horse. Same thing with neuro, just apply that. This is applied to bio, apply it to neuro. We need to be forecasting and imagining these kinds of models and possibilities because somebody's already shot across our bow. This is a clinical trial in the wild, and they've used the target to be American officials. Now we've got two instances. We don't know any other instances other like this. So you have to assume it's a purposeful, targeted attack. Okay? We got the message. So let's talk about this. This is very interesting. Let me start with the data set in the middle, which is what is apparently legal. That's what's legal in terms of conflicts. Notice it's psychological effects, psyop stuff. It's basically dysfunctionality, rendering, lack of capacity, acoustic weaponry. All right? This is about 10 years old, this slide. So it's not like this stuff is new, it's maybe being deployed in a new way, okay? I also want to point out that the effects and the effectiveness, we have had a lot of data. You've heard from our eminent faculty of doctors that this is one, credible, two, here's what it looks like, and three, here's the science. So I'm not going to go through all that. But I also want to point out that this is a patent from 1999. I did a scan as part of research with my team, looking at patents. And when you look at patents, it gives you a sense of intellectual property of what people were thinking about that they wanted to do. 1999, you've got an acoustic hydrodyne weapon, U.S. patent 588, et cetera, March 30th. And it gives you a sense of what are the possibilities to be able to, what the science may tell you, okay? So, also, these are devices that are being carried around from various sources. This one is from Canada, backpack. That's Moore's Law, the operationalization of Moore's Law. But these are also devices that have been used for crowd control, larger populations, but they're targeted uses that are portable. Slide, please. These are examples of deployments, real-time deployments. Again, am I saying they're exact for what we've seen in Cuba or in Asia? Similar, but these are for crowds. The circle is the devices that are mounted. Some of them, I'm not going to get into exactly what the actual technology is, but as you can see with the people with their hands over their ears, it's having an effect. Okay? So it's not like this has not been fielded as well. Okay? I want to also say that, the neurohacking, which is maybe a term you haven't heard of, the ability to be able to create bots, but also I mentioned that earlier, blend it with AI, but sensors and networks, we haven't talked about that, the ability to be able to deliver this. So these devices, which we think that were used either externally to the habitats where the subjects were targeted, or it may be internally, but we haven't talked about whether there could be other kinds of devices such as flyables, drones, or they were tied to other sensors, or sensors were hacked. Where am I really going with this is that in an era where everything is hackable, health devices, routers, I bet you, a large portion of the folks listening to this in their home, and we have some experts here who can attest to this, that most devices that are now networkable are what? Hackable. And neurohacking, we're just, as we develop devices to adjust or refresh memories, which we will have at the nanoscale, you don't even need them at the microscale, you're going to end up, everything that can be made can be hacked. And neurohacking is an area that we don't even have people really thinking about yet because we don't have all the devices, but that's where we're going. That's part of the story that we're learning today. Okay, slide please. So weaponized neuroagents, interestingly, this is kind of heading towards our bad guy actors here, for all intents and purposes, in the era of nanoneurobiology, synthetic biology, molecular delivery, the ability to deliver these agents, it doesn't have to be that sophisticated. We've had 2 events of the use of neurotoxins that should show us. So one part of the continuum is kind of crude weapons, and they're clearly weapons, right? The neuroagent, the Russian neuroagent used in Europe against targets, that was purposeful. Then we've had another example of the agent used to inflict insult and mortality against in North Korea, in Asia, against a North Korean ex-resident. So for all intents and purposes, you are now talking about, that's the crude part of the neuro supply chain. This is a more sophisticated, non-lethal part of the neuro supply chain, neuro weapon-only supply chain, right? But I would forecast there's going to be a lot more. We'll talk a little bit more about that. But it doesn't have to be as sophisticated as this. And this, again, we don't have time to prosecute this, but in the modeling work that we've done at Potomac Institute for this conference on war and the implications of neurotechnology for that, we modeled out a variety of things, of which we've done about, since that time, which was I think 2014, about half of these are now deliverable as capabilities. So the other part of this, as we make a transition now from talking about really kind of an overview of technologies and drilling down on neurotechnology, I want to talk a little bit about that. The other complementary side of this is the geopolitical implications, and of course, who might be potentially interested in doing this. So this is, again, a body work that I had developed when I was advising SOCOM around bad guy hunting targeting, and I came with this concept of dark networks. Dark network is a criminal, terrorist, sometimes sovereign, who work together in a supply chain to be able to create and implement and plan and deliver. So in these global dark networks, which is kind of what has evolved, there are a variety of actors. Rogue states, radicals, non-states, criminal, who are involved in a variety of parts of a supply chain that you need to be able to make stuff, deploy stuff, and produce disruption and conflict. You have to have banking, you've got to have logistics, you've got to have things to trade that are non-monetary. You need to have crypto. Where's our crypto friend? There he is. Call out to the crypto world. Cryptocurrencies, you've got to have the ability to be able to have other monetary forms to support your operation that are non-transferable, discoverable. You need to have a complete supply chain. Think about it like, Walmart has a supply chain, right? They grow stuff and make stuff all over the world, and they figure out where to ship it to assemble for the best taxes and which monetary unit to use where, to deliver to what markets or where. It's a supply chain. So dark networks have supply chains. Criminal and terrorists and sovereigns, bad actors have supply chains. So if you're in the bad guy hunting business, right, you gotta understand the supply chain. Follow the money, follow the logistics, follow the customers, follow the producers. So when we start to then apply that thinking to, who are potential bad actors that would do this and why, you have an interesting model. So I built a model around that I've used before. But you start to also look at what does the literature indicate regarding who might be interested. The Russian view of modern warfare is based on the idea that the main battle space is the mind. Well, interestingly, remember I said earlier about the supply chain around neurotechnology. You've got on one end blunt tools, right? Use neurotoxins to take out parties. You got subtler tools, which are information warfare, right? And now we've got more aggressive stuff, penetration of elections, fake news, fake identities, and all that. And then you've got these even subtler kind of non-attributable phenomena, which is these incursions in Asia and Cuba. It's part of the same thing. You might add to that also, Syria and other folks that are using neuroagents. So again, you want to start thinking about these as supply chains, ecosystems of involvement. So let's take a look at, this is the bad guy hunting threat analysis. And I am working with a couple of other folks in this space. One is Sensing about bad guy hunting. But let me give you a kind of I'm not going to go through all these, but let me give you kind of a list and then I'll prosecute a couple of them. So the threat analysis it basically cuts around, who, what, where, how, and why. Not hard to figure out, right? That's what we're looking at. Identity analysis is, what is this? Is it an agent? Is it a device? I think, again, I'm not going to go back into what our distinguished doctors had outlined for us because I'm in complete concurrence. I think it's important as a takeaway is this is not, as far as I'm concerned, an accident or some happenstance. This is a directed, purposeful target at a population that are American officials, and I understand there may be other officials from other friendly nations, but for all intents and purposes, this is a capability analysis that's been deployed, targeted, chosen. Okay. So The second is kind of benefits, wins and losers. Who benefits from this? Who benefits? Well, the first order of benefits are the folks that are perpetrating this. What are they doing? Demonstrating a capability set. Why would that be useful? Who would benefit from that? It's useful to be able to determine what the impact is, and did the impact confirm what our objectives of that was. I said earlier, this is a clinical trial in the wild on humans. The second order of that is against whom? Well, the whom is Americans. That's very valuable to who? Well, that's a short list of people that would sponsor that. And maybe they didn't sponsor it, but maybe it's bad actors, rogues, that are basically advertising. We'll get into that a little bit more. I talked earlier about vendor supply chain, so I don't want to go into that, but I would say the vendor part of that is very interesting. I bet you today I can find similar pest control devices in Baghdad over the internet. I ran an operation where I was putting together, I needed a drone delivery. I picked up the internet, found 4 or 5 places throughout Baghdad, Iraq, Afghanistan, Paris, Marseille, to put together an order. Nobody ever asked me why I wanted it. Could I find pest control devices and a variety of other technology that are clearly available, and I can ship them from FedEx, maybe even buy them on Amazon or Circuit City and have them delivered, not Circuit City anymore, but Best Buy, yeah. So vendor and supply chain is very interesting. Ideologic for-profit research, likely all of them. Probably the least is ideologic. So, you think about things as ecosystems of interacting and related folks. Don't be fooled by ideology. 80% of the bad guys are doing it for some kind of profit. They're in the game. I mean, the fuel that drives ISIS is the oil. It's a commercial enterprise, the Taliban. Also, number 6 is interesting, geopolitical signaling and payback. What has occurred recently in terms of, what's the short list of trade sanctions that are currently been deployed? Against who? It's a short list. Look at the list. Is there a geopolitical payback of which this event might be related to? Or what are the implications of that? It's a short list. 4 major countries, not hard to figure out. Rogue, sovereign, dark network, we like to, we spend a lot of time trying to figure out, well, is it this or is it that? Maybe it's all of it. Maybe it's a carve-out that doesn't know and they're playing. So at the end of the day, likely this event is a contractor looking for business and wants to prove up a capability. And you got to think, well, wait a minute, Cuba, kind of get that, a backwater, we don't really have a embassy per se, in China, given the treaties that are associated with this and the target of the population. Wait a minute. So that, in some ways, who does that eliminate? Probably eliminates China. And it probably, then you start to ask yourself, who would benefit from China being embarrassed with this insult occurring where they're responsible, based on the treaties, against Americans? That's a shorter list. Or it could get more complicated because you've got what I call, we'll get to this, a fractured sovereign scenario. Okay, I don't want to go into all this. It's like, if you look at the incursion in India, back in the day in Mumbai, that was an advertising for a capability that was deployed someplace else in the world. So that you got to think geopolitical in terms of, what are the largest cities? What do those supply chains look like? And don't look at me over here, I'm going to try something over here, but I'm really interested in showing this capability for something else. Think about it like the history of comparable events for analogous deployments like cyber. could neuro end up looking like cyber? And the answer is yes. It's a proven up model. In fact, a product line extension from cyber would be neuro. Why not? Hey, we've done great with cyber in terms of our profit center, and now we've got a new capability. Who wants to sign up? Prove up the capability. The commercialization of weaponized technology is a key driver, more so than ideological. Here are just the possible scenarios, and then I will move forward. Fragmented sovereign is, most countries have a variety of, warring factions that have different perspectives, ideologic, political, economic, and for various reasons. These competing forces in regions and nations produce what we call fragmented sovereign. And fragmented sovereign scenario says your bad guys basically have implemented this, that we're talking about, this neurointrusion, because what? Because they're trying to accomplish something else. You got to think 3 steps ahead. Well, they do this to be able to engage this, to get people busy over there when they're really interested in something over here. Fragmented sovereign. Second is terrorist clinical trial. These are pretty self-explanatory. Likely, I would bet on this as rogue actor practice. And that this is a messy clinical trial because they get to do what? They get to have the Americans who have the best research to go ahead and analyze it, bring in the best doctors, and then do what? Open democracy, publish all the data. Publish it all. Do all our work for us. Thank you very much. Now we know, and what's better than the Americans to be able to analyze this? Because I can't find any Chinese reports. I see no Chinese data, very few Chinese reports, no pest control, Chinese denials. So this is somebody that understands. Now again, I'll give you the profile, right? This is a private sector bad actor who understands what? He understands social media and information warfare. Clearly wants to advertise his capability, wants to embarrass the Chinese, or at least put them in play, and is attacking a select group of State Department officials that have functions in 2 nations. Now, who's on that list? That's a short list. That's a short list. Do the math on that. And then a dark network show of force, criminal terrorist organization that, again, they'd only do that, I think, because of a commercial interest. Sorry, slide please. So let me just say, let me make a forecast and look forward. So you have to assume that we're at the beginning of neurotechnology being now incorporated into this kind of hybrid conflict era, number 1. 2, you should recognize, and I would suggest that we are looking potentially at additional instances. Why? Because this has been so effective. Americans played their part, host country played their part, a lot of good data. We're getting more data. Aren't we getting more data? That's great. Cuba, China, we got more data. What's the next target? We don't know. It's likely it's not going away because it's been an effective trial. But it now is revealing as a deployment. And of course, the insult is that it's not, we're not talking about rocket science, we're not deploying, some laser quantum fusion cannon, there's not like super sophisticated technology, which makes it even more interesting. So you're likely looking at, as I said earlier, the 2 parts of neurotechnology. The soft part, for all intents and purposes, is, hey, you're talking about cognitive dysfunction, to be able to deliver a deliverable as cognitive dysfunction to impact what? Decision-making, operations, negotiation, communications. That's a big deal. The hard part is I'm less interested in. I don't think the design of this weapon is to kill or maim. I think it's to take parties out. And likely these are these State Department officials are not folks that are going to be able to go back in the game. So you got to think about that as a kind of a long-term impact and risk factor of which there could be additional locations. Is it possible we could be looking at super drones that could deliver this in terms of capabilities? Yeah, well, we haven't looked at it, but yeah, that's a deliverable. It's episodic, it's acute, it's here, it's gone. You can deliver from various levels. There are questions about the ability to be able to deliver echolocation and these other targeted things from 35,000 feet or 5,000 feet, and we don't know the answer to that. But there are devices that give us capabilities, and again, shrinking stuff down. So in summary, let me just say to you, one, neurotechnology is here, it's not going anyplace. It will likely shape the competitive advantage of nations, organizations, and individuals. And that's for both good, bad, and ugly. So let's get on with it. It's here. Second is that the attacks in China and Cuba appear to be purposeful and directed at a population that, by the way, could be expanded. And three, the target U.S. officials is revealing in itself. And there have been no other instances similar to this, similar pathology, similar any place else that we're aware of. So I think somebody is sending a clear geopolitical message. It is a bad actor, whether they're in alignment with other sovereigns in that. So who would gain from this? These sovereigns, again, is a short list, but it's clearly signaling, a geopolitical signal. There is a communication going on. A new neurokinetic weapon would be disruptive in an era of hybrid conflict. And we have to assume that we are in a new era. And that new era purports that we have to have a way to deter, prevent, and detect. Thank you.